Again, thanks for coming out. And today I have the exquisite pleasure of introducing our keynote for today, Dr. Dimitri Daskalasis. He is the Assistant Commissioner of the Bureau of HIV Prevention and Control at the New York City Department of Health and Mental Hygiene. He was educated at the NYU School of Medicine. He's done trainings at Beth Israel Deaconess Medical Center. Has a MPH from Harvard, and he's done a lot. He's done a lot of great work in LGBT communities, a lot of innovative work in HIV testing, a lot of great innovative work on the ground, working with HIV, particularly testing, and has done some very innovative studies looking at work that can advance biomedical interventions to reduce HIV risk among high-risk groups, particularly in regards to pre-exposure prophylaxis and post-exposure prophylaxis. So we're lucky to have him here. We thank him for his time.
Great.
Take it away.
Thank you. Thank you so much. It's an honor to be here. I'm really honored to get to come down to Louisville and to present. And by the way, your presenters have been awesome. I think that's some of the highest quality presentations on both the legal aspects of PrEP as well as the awesome presentation on how to, really good, basic info. How do I get this paid for? So my job is to totally destroy the idea of giving you anything useful and talk about data. No, I'm just kidding. It's going to be the background, and then we're going to go deeper into it just so you have a sense of pre-exposure prophylaxis. But I really start off by just telling you that today we're going to be talking about the epidemiologic urgency of why we're talking about this. Why is it important, and why is it an emergency that we operationalize PrEP? I'll talk a little bit about clinical trials to help you engage with the data. You may have already seen it. In fact, that great graph that you saw with that line of adherence, that's pretty much everything I'm going to present, but in a bit more detail. And then talk a little bit about PrEP guidelines that are out there, with a little bit of a focus on the New York State ones, even though they're very similar to the CDC, and talk about how that can be integrated into day-to-day practice. So I start out by just defining antiretrovirals for prevention. So the way that I like to divide it out is that there's event-driven prevention and risk-driven prevention. So that we're going to call sex, drugs, and rock and roll. Something happened. That's an event, a risk event, a chance of potential exposure to HIV. So if someone has a risk event such as that, you can start them on post-exposure prophylaxis, or PEP, which I imagine would be covered under that statute for adolescents, which is an emergency, just by the way. So the good thing about PEP is it prevents HIV, but the bad thing about PEP is if you think that it's complicated to do PrEP from the insurance perspective and access, you have another thing coming with PEP. It's really complicated. There can be more risk exposures. So someone can have ongoing risk. What we know is that people who do PEP, they don't seroconvert while they're on PEP. What happens is 3 to 6 months out, many of them or some of them will get HIV. It doesn't have to do with the meds failing. It has to do with the fact that the behavior that got them to PEP continues. So if they have another exposure, you can do PEP again. But what happens if there's so much sex, drugs, and rock and roll that you can't keep up with PEP every 2 minutes? That's when you start thinking not about the event, not about the emergency, but about the fact that people can acknowledge that there's a level of risk and there's something they can do with that level of risk to modify their chance of getting HIV or transmitting it. So for people living with HIV, there's TASP, treatment as prevention. So that technically is a twofer. You get treatment, you prevent complications of HIV/AIDS, and the second thing you get is a nearly negligible risk of HIV transmission for people who are virally suppressed or who are taking their meds every day and their viral load is below the limit of detection. So that technically is risk-guided prevention, but it's kind of an afterthought, a side effect of the fact that we're treating people who are living with HIV effectively. But how about for people who are negative? Well, that's where PrEP comes in. So PrEP is risk-guided prevention for HIV-negative people, and as you've heard over and over again today, it's a pill that people can take once a day, and that prevents acquisition even in an environment where you have ongoing risk-taking. So that's really just the just definition of what this means. And so today we're only going to talk about PrEP because that's the theme of our conference. And so I'm going to talk a little bit about what we know of preventing other infections using medicines and other strategies. So I'm going to present two models, and you're going to see that I have a favorite of the two. It won't be subtle. So model one, I'm going to talk about something that we deal with all the time in clinics, which is malaria. So when you travel to a part of the world where you can get malaria, what do? So you should always use bed nets all the time, avoid mosquito exposure, so just don't leave your hotel. Because if you leave your hotel and you get malaria, I'm going to judge you for getting malaria. So when you're in a behavioral or epidemiologic environment where HIV risk is high, what can you do? So following that similar model, you should always use condoms 100% of the time for all sex, all the time, only have one partner, don't have an HIV positive partner for God's sake, and if you want to get pregnant and your partner's positive, forget about it. Or if you get HIV in that scenario, I will judge you. Right, that's model one. So what happens when you look at model two and remove the judgment aspect? When you travel to parts of the world where you can get malaria, yes, bed nets are a great idea. You avoid mosquitoes as much as possible. But ultimately what you do is you take anti-malarial medications, that's malaria PrEP, to prevent malaria acquisition. So when you're in an environment where you're passing in and out of HIV risk, PrEP provides the opportunity to do the same thing. You should always use a condom. At least in New York City, we'll never say that you should always use a condom. That's a great idea. But the reality is, sometimes people don't do this or won't do this. So rather than judge them for getting HIV or the potential for getting HIV, you have the ability to give them the HIV PrEP, which is tenofovir emtricitabine fixed dose combination, no free ads for anyone. That is a way to prevent HIV acquisition. So what about condom effectiveness? So let's really talk about the reality of condom effectiveness and why this may be an important supplemental strategy to certain populations. So we know that consistent condom use, used correctly, prevents STIs, including HIV. Dawn Smith from the CDC did a really fabulous study where she looked at the actual effectiveness of a condom, specifically in certain populations when they have serodifferent partners, or serodiscordant, depending on how you want to refer to them, so, or magnetic, where one is negative and one is positive. So in this analysis, she found that for men who have sex with men with consistent condom use, there's a statistically significant value to a condom with about 70% effectiveness in preventing HIV in that circumstance. But when that MSM group doesn't use it consistently, when they have occasional condomless sex, it loses statistical power. So though it does work to prevent STIs, it loses its ability to prevent HIV as well as a population-based strategy when they're not being used consistently. And I think that when you talk to people who are in the world, they'll tell you that their condom use, some of them, is not consistent. So that's why it's important to think about another thing to supplement. Same is true for heterosexuals. So I'll tell you that in Dawn's study, 16% of MSM reported consistent condom use, 1/6. Which means that the other ones of them potentially are candidates for pre-exposure prophylaxis. So that's why it's so important. And so I show you this, which I'm also going to give you a spoiler, which I'll get in trouble for in New York City, but I don't think any of you are going to fly back and tell on me. Maybe. So this is a slide I show because it sort of talks about the lessons that we've learned in the past about HIV prevention and how we can pull them into the future. So when there are people who were pregnant with who had HIV, very often what happened was we didn't have a lot to offer them, and their babies would be born with HIV in the early 90s and in the 80s. So something happened. Studies came out that showed that if you actually used HIV medicines in that context, both for the baby and for the mother while she was pregnant, you could prevent transmission of HIV. And so when you combine the strategy of counseling as well as a medication, what happens is this curve goes down. And so I'll tell you that in 2015, we're going to report 0 transmissions from mother to child in New York City. 0. Right? Amazing. And so what did it? It wasn't us saying you better not have babies, better not have sex. It's saying that if you're pregnant, we have a way to prevent transmission to your child, and this is how we do it. So if you think that story is good, what about the story of injection drug use and MSM in New York City and New York State from the perspective of HIV transmission? Something happened in the 90s here that changed the story. So this is the proportion of new diagnoses that are IDU and MSM, right? So injection drug user and men who have sex with men. So what you see is there's been a reversal. So there used to be a lot of cases in injection drug users. They were the majority of the cases. Then something happened here, and then all of a sudden, their rates went down while the rates of newly diagnosed in MSM continued to, quote, climb, mainly because they were stable and fewer injection drug users were diagnosed. That's a percentage, right? So it changes depending on what the denominator is. Well, the bottom line is injection drug users, two things happen. We started treating HIV effectively. We got viral load suppressed in the community, and what happened was people were less likely to transmit. That is not the story, the end of the story in injection drug use. That's when syringe exchange was launched in New York City and New York State. And by creating something where you combine biological intervention like HIV medicines and harm reduction, all of a sudden, you've changed the story. So this is yelling at us and saying, what is our harm reduction strategy for sexually active MSM who may not be using a condom every time or using it effectively? PrEP is syringe exchange for sexually active individuals. PrEP is harm reduction for MSM and people who are potentially at risk for HIV exposure. So if we take our lessons from the 90s and move them into this decade, I think we have an opportunity to blend biomedical intervention, counseling, and harm reduction to create a strategy where we're going to grab that curve and bend it down, just like we did injection drug use and maternal to child transmission of HIV. Our lessons from the past are going to guide our future. And our future is this, unless we change it. So who's seen this one before? Yeah. So this is a mathematical model released by the CDC that uses a lot of data sources to estimate the risk of people becoming HIV positive sometime in their lives. And so 1 in 99 in the US are, at least according to this model, potentially destined to get HIV at some point in the future. The darker the state, the more likely that folks are going to get HIV. So again, this is a model. We can interrupt this, but before we get into interrupting it, let's look at some of the details of that model. And so this is when you look at heterosexuals. What you see is that there's a couple populations that specifically are at highest risk for HIV acquisition according to this model. A black woman in the US, according to this model, has a 1 in 49 chance of getting HIV at some point in her life. A 1 in 86 chance for heterosexual males. So as you see, there's an emergency, and it requires us to actually be not blind to race, but in fact use our health equity lens to identify a strategy for ending this epidemic in populations that are overrepresented. And so then when you go from that to MSM, the data becomes, the model becomes even more bleak, where you can see that the estimate is that 1 in 6 MSM will at some point in their lives get HIV. Remember, in this model, the CDC counts trans women in this as well. So it's transgender and MSM. So when you look even deeper into this, this is the stuff that you've heard in the news, that the model says that 1 in 2 black MSM could potentially acquire HIV sometimes in their lives, 1 in 4 Latino. So my job to tell you here today is that this is not to depress you. This is to remind you, this is a mathematical model that we can interrupt. We have the ability, if we change the status quo, to interrupt the model. Treat more people living with HIV, get their viral load suppressed, they won't transmit. Identify people at risk for HIV exposure who aren't using traditional mechanisms for prevention, and lead them to the newer methods of prevention, including PrEP. And this does not have to be our future in the US. So I'm going to leave the soapbox, the pulpit, as it were, and instead go straight into some of the data, which you've already seen a little bit of. And I'm going to go through by special population that was studied. So first we'll start with men who have sex with men. So this is IPREX. This is the study that really generated, at least from the MSM perspective, the approval at the Food and Drug Administration for tenofovir emtricitabine fixed dose combination for PrEP, which is the one drug that's approved. So this study did something pretty straightforward. It screened 5,000 men who have sex with men. It was international, and then it randomized 2,500. But before I leave here, this is a really boring data slide. I swear I'm not going to hypnotize you after your delicious carbohydrate-laden lunch. But what I'm going to do is actually tell you why you need to be angry. And so I'm going to walk up in a dramatic fashion and point that 10% of the people screened for this test, for this study, landed and found out they had HIV. 10%. That's intolerable. That's very, very high. Ultimately, though, 2,500 were randomized, and they either got PrEP or they got a sugar pill. And then they followed them to see if what happened from the perspective of getting HIV. And what they found was that there was a 44% reduction in HIV acquisition. So for those of you who don't have a Master's of Public Health, I am going to give you your first tutorial on a survival curve. You'll understand this one, then all the rest will make sense. So this is the y-axis. That's the chance that someone's going to get HIV. The higher that number, the more possibility they're going to get HIV. The x-axis, that's the flat axis, that's the weeks since they entered the study, how long they've been followed in the study. So the red line is the sugar pill, and it's higher than the blue line, which means that the people who were getting the sugar pill were more likely to get HIV than the people that were taking the real medicine. Does that make sense? Okay, you're going to see this over and over again. So when I show you this, you'd say, if this were a flu vaccine, I wouldn't sign up for it. 44% doesn't sound very good, right, in terms of how well it functioned. But I'll tell you that if today we had an HIV vaccine with 44% efficacy that was demonstrated over and over again, you'd have lines out the door. The FDA would approve it as an emergency. Like, it's really not a bad number. But there's more to the story, and you've already heard a little bit about that. What they then did was, in that same study, they looked at the people who were supposed to be taking the drug, not the sugar pill, the real drug, and they compared people who got HIV, who were supposed to be taking the drug, to those who did not get HIV, who were supposed to be taking the drug. And what they found was that the people who got HIV didn't have drug in their system, or not very much of it. They weren't taking it. But what they did see is that if you were taking the drug, there was a 92% reduction in HIV acquisition. Please note that does not mean 100%, 92%. If that were a flu shot, you would definitely be happy. That's better than your average year's flu shot in terms of preventing HIV. So it's pretty remarkable. And for people who actually take care of patients or who see patients, not surprisingly, taking the drug means that it works. Not taking it means it doesn't work. So bottom line is, adherence is critical. In fact, the smart people in the IPREX study did something pretty cool, which is they took another study that they worked on where they gave a lot of doses, different dosing schedules to HIV negative people and measured levels. So they said, what happens if I give people 2 tablets a week, 2 to 3 tablets a week, 4 to 6 or 7, and they just measured levels. They then took those levels and superimposed them on the IPREX study. And what they found is, if people took better than 4, men who have sex with men took better than 4 tablets per week, they had really good protection against HIV. So the lesson here isn't to say you should only take 4 a week. The lesson is, the more you take, the better it is, and the better it protects you from HIV. And so even PrEP has forgiveness for adherence, but the more you take it, the better it works. That's the lesson from that. And speaking about the more you take it, the better it works, there was a study that came out called Hypergay. It is a French study that happened in France and Canada. And what they asked the question was, what if you don't take PrEP once a day? Instead, what if you take it on demand when you're going to have sex? And so this is their idea. So you have people who are going to have sex, and they make a plan 2 to 24 hours in advance to take 2 doses of Truvada. I said the name. Here, that's what sex looks like in France. It's a lot better in New York. I can only imagine what it's like here. But that's the sexual encounter. And then after that, they have to take a dose of PrEP every day for 2 more days. Confused yet? A little confusing. Okay, well, so what they found was it worked. 86% risk reduction in the PrEP arm, excellent adherence, safety similar to the sugar pill. There was no evidence of risk compensation, which means people weren't less likely to use condoms or have more condomless anal sex, at least in this phase of the study. But the details are important. French guys have a lot of sex, apparently, because they were taking up to 16 doses per month. I'm not a magic mathematician, but you divide that by 4, it's about 4 a week. So they were actually taking plenty of PrEP. So technically, according to the IPREC study, they probably would have been pretty well protected. It ends up that when they did an open label piece of the study, that number went up to 18%, and the condom use also went down. So people actually knew they were getting PrEP. They also showed something really interesting was that 60% of sexual encounters that should have been covered by PrEP weren't covered by PrEP. So let's play this through for the way that we think about condoms. Who's heard this one before? I saw someone who I wanted to have sex with. He looked fine, so I didn't use a condom. Heard it? So now it's, I saw someone I wanted to have sex with. He looked fine, so I didn't take my PrEP. So the decision-making went back into the story. And so New York State, CDC, New York City, we all vote that this is an interesting idea, but not one that should be your mainline idea. The daily PrEP is the right way to go because you, A, remove the decision from the heat of the moment, and also deal with the fact that, that maybe American guys have sex less often than French guys. I don't know. There's also some really good real-world implementation, mainly around men who have sex with men, that show that PrEP works in the, quote, real world. So one of the, quote, real worlds is the London STD clinics, which are kind of a wonderland from the perspective of how well they function. But they actually launched a PrEP study there, and it was you either started right away or you had like a year to think about it and have counseling. And what they found is that individuals who were on the immediate PrEP arm, who started right away, had an 86% reduction in HIV acquisition. That's huge. They, however, had a high rate of STIs when they began, and they had a high rate of STI after they kept going. So STI is a real serious piece of this that requires brainstorming and discussion about how to sort of improve services around that as well. What they found was that in order to prevent one case of HIV, they had to treat 13 people. Okay, so here's a fun comparison. How many people do I have to give cholesterol-reducing meds to reduce stroke or heart attack as primary prevention? Anyone? Anyone? It's 187, right? So technically, this is a more efficient intervention than what we do sort of at baseline as like a no-brainer in our clinics. Kaiser Permanente claimed that they have data that represents people in terms of a real live implementation of PrEP. Okay, no, because San Francisco's different. Like, this was a very intensive program, even though it was, quote, real world, but they did primary care-based PrEP, and what they did is launched it, and they expected in their analysis, in their mathematical modeling, that 8.9 per 100 person years, about would have an HIV seroconversion in that study, right? What they actually found is that zero. That people who were taking their PrEP, there were 0 seroconversions. So PrEP worked in that setting. With that said, 50% of them eventually had an STI, which should not be a surprise to anyone. It should not be a shock. So let's leave like MSM in general for a moment and really focus on young MSM because this is where it gets very interesting. There was a study, ATN 110, and what they did was they put young men who have sex with men, 18 to 22, into a study. The details are kind of unimportant, but what they found was a higher than expected HIV seroconversion rate than they had seen in other PrEP studies. So though there was something that looked like it was working, it did not work as well in the younger guys, which raised some concerns. So what they found was, this is just a graph, that's a stacked bar graph that shows you drug levels based on their weeks of follow-up. So they start their meds somewhere over here, and they come back week 4, week 8, week 12, week 24. So what you can see is red is bad. That means that they can't detect drug in their blood. What you see then is that once you loosen up the follow-up for the adolescents, they don't take the medicine as much. Right? So all of a sudden, when they were seen once every 4 weeks, things were kind of peachy keen. And then the more time you had away from them, the less likely they were going to take the medicine, really raising the possibility that youth need a different model for follow-up than adults for adherence. But then the news gets even more complex. They actually then broke it down by race. And what they found was that, that the young white men who have sex with men and the Latino men who had sex with men actually get above this dotted line of 4 doses per week. You remember that 4 doses per week, right? That's the one that matters. That means that you've got a good level of protection. So they get up and stay up over it. But when you look at the black or African American young MSM, they barely touch that line and they peter off. Really, again, raising the point that when you look at launching PrEP programs, you have to be very sensitive to the community and try to figure out what's appropriate for them and what are the other needs that you may have to address along the line that will support adherence. Something that comes up all the time in youth is what happens to their bones, because there's some concern that that tenofovir, which is one of the drugs in PrEP, may cause bone problems. So this is from a sub-study of the one I just showed you, and I'm not going to have you read all the numbers, but I'll just tell you what they mean. So this is what their bones were like at baseline. So this is like a normal reading for their bones. Then what happened is they go on PrEP for 48 weeks, and you see that their bone mass goes down a little bit. Some people then stop PrEP, and what happens is it goes right back to normal. And the people that decide to continue PrEP, it doesn't go back to normal, but it doesn't get much worse. So it sort of stabilizes and stays there. So the reason that I show that is because even in youth and in adults as well, you can see a change in bone mineral density, but what's important to remember also is that none of the studies actually show fractures. So that's not a trend that they see. But if you measure it, which we don't usually do in this age group, you'll see a change related to the drug. So then in a follow-up study, they actually looked at even younger men. So they went to 15 and 17-year-old, born male, HIV negative, and they went through a whole list of things that would make them qualify for the study. My favorite one is at least one episode of Condom Malfunction, wink, wink. So they've really tried to make it like very inclusive into this population. So they recruited 15 to 17-year-olds, and guess what? Remember that last graph? It was the same. Same story where they saw an increase in white and Latino men, but this time all of them crashed down when the follow-up becomes less frequent, really raising, again, the issue of do they need better follow-up. When they looked at people who seroconverted, again, they had more seroconversions than they would have expected compared to other PrEP studies, but none of them actually had enough drug in their body to even hit the four-dose minimum. So it was a question of adherence. So the conclusions are, I guess, adolescents are important to deal with for PrEP because they are like one of the growing communities for HIV, important for us to work on that. We need to decrease regulatory, sound familiar, and financial barriers for them to access PrEP, since that's exactly what we were talking about minutes ago. PrEP was well tolerated, but that adolescents are not small adults. Which people who take care of adolescents will say that and say, of course, but it's important to remember that you may have to customize their care a bit more and may need to see them more frequently if they are on PrEP. Okay, so we're going to leave that MSM universe and go into injection drug users. There's only one study that I have to report to you, which is the Bangkok tenofovir study in injection drug users. In Thailand, they screened 4,000 people, and yes, as apparently is the trend for all of these PrEP studies, 10% of them found out they had HIV that day, intolerably high. So they get into the study, 2,500, and they're randomized. They either get, we're just going to call it PrEP, it's a bit different, they only get one drug, but PrEP versus placebo, and then they were followed forward, and look familiar, it's just like the last one I taught you about. But this time they tried to confuse you by making the sugar pill blue. But the same trend is there, that you see that there is a protection afforded by being on PrEP, which is TDF or tenofovir, and in this situation, it was a 48.9%. Now, if you actually look to see who had it detected in their blood, it goes up to 70%. So even for what is thought to be the highest risk exposure to HIV, which is syringe sharing a needle, you actually see improvement. But remember, people who inject needles, they also have sex. So in some populations where you may have effective syringe exchange, PrEP may be important, especially if there's transactional sex to acquire drugs, because you pay more for condomless sex than for condom sex. So just something to think about in the world of folks who are doing exchange sex. Okay, there's a lot of data in at-risk heterosexuals, tons of it. Partners PrEP is probably the coolest of all of the studies that do this. So what they did in this one is that they recruited about 5,000 people who were in sero-different heterosexual couples, and they either went on PrEP or sugar pill. So they did more studies with a couple different formulations of PrEP, but for our purpose today, we're just going to call it oral PrEP. It's easier. in terms of making the point. So oral PrEP versus the placebo sugar pill, and it is a twin of everything else I've showed you, except these folks really took their meds really, really well. Super high level of adherence. And what you see is that the placebo had way more breakthrough infections than the folks who were on either formulation of PrEP. And so they actually reported a 75% efficacy for tenofovir emtricitabine and 67% for tenofovir, and they're not different mathematically, they're the same. So the news there was if you took the medicines in heterosexual couples, it works. They then did something which I think is then even cooler, level 2 of this, called the Partners PrEP Demonstration Project, where they ask my favorite question, which is what if you put all of the mess together, both treatment and prevention using antiretroviral therapy, what happens? So I'm gonna walk up there again. So what they did is they recruited partners very similar, one that was negative and one that was positive. The positive partners not treated, and they offered interventions. They got to pick which intervention they wanted to do. And so they could go on, the positive person could start antiretroviral therapy, and the negative person could start PrEP. And if they chose to do that intervention simultaneously, what they did was kept the person on PrEP for 6 months after the person with HIV got virally suppressed. So when this person becomes undetectable and stays undetectable for 6 months, they would drop the PrEP off the HIV negative partner. This one is just the fact, this just sort of demonstrates the fact that, you know, if people change their mind about how they wanted to start, there's still 6-month overlap. That's the part that matters. And so what they found was, as is typical of these partner studies that Jared Baden does from University of Washington, they had a huge level of retention. So they had a great amount of follow-up. They had a high use of people who said, I want to start PrEP and HIV medicines. So 97% of the negative folks at risk initiated PrEP, and 82% of them had levels, 82, really high. For antiretroviral therapy, 91% initiated at 24 months. And for those of you who follow continua of care and cascades, 90% were virally suppressed. Huge. So really, really good adherence. And the next thing, which is more of like a stereo instructions detail, is that the results of the study, different interventions were measured, represented a different piece of the measurement time of the study. So I just want to have you have a sense of what the effect was. So PrEP alone time was 20%. People who were on PrEP and antiretroviral therapy, so the negative and positive partner, represented about 33%. Treatment alone represented about 39%, and neither was 7%. And they saw over time a decreased use of PrEP, as you would expect, because people discontinue it. What did they find? Well, what they found was, and I'll have you see the graph first, that they estimated they would see 83 infections in the study, and in fact, they found 4. The strategy demonstrated a 97% effectiveness in women and 97% in men and 93% in women. They even saw an effect in youth and in people with higher viral loads. But I'm not leaving this slide yet because you have to understand the story of these 4 people. These 4 people were neither on PrEP or on antiretroviral therapy. They were the 7% that weren't on either. So if anybody was doing anything, PrEP or antiretroviral therapy, there were 0 transmissions, right? Amazing. So you put the whole mess together, combination prevention of both looking at treatment and PrEP in the same way, and you make a significant change. And potentially, this is like the line, like this is what Jared Baden put up at, I think it was the international meeting. So the fact that we can say this in 2016 is shocking. Integrated PrEP and antiretroviral therapy delivery led to near elimination of HIV transmission. Right, that's like earthquake. Real world demonstration, this was not a study, they were just out in the world doing their thing and they were just followed, showed that it worked. PrEP may be a way to be a time-limited bridge for people who achieve viral load suppression in discordant couples. It may be another strategy. And it maximizes the use of treatment, which is, again, a twofer. You prevent HIV complications and also prevent transmission. Okay, another study that doesn't look at couples, but looks at people who are just out there having sex in Botswana, where HIV is everywhere. They recruited folks and they followed them, PrEP versus placebo, and I'm not going to beat you up with this again. Placebo didn't work as well as PrEP. In this situation, it was 62.2% efficacy. So even in people who weren't in couples, who were just out there having sex, PrEP worked. Again, this is an African study. But there's something to remember that's different in men and women. This is one of those lessons that you need to know, especially if you're counseling patients or talking to patients. This is a really mean study. What they did is they recruited people and they got a single dose of PrEP. So they got tenofovir emtricitabine. And then they did rectal biopsies, vaginal biopsies, and cervical biopsies. Thus the mean study. So the reason that you don't see a lot of things in between here is they didn't biopsy them every day. They gave them a break because it was just a lot. And so what you see is that when you take that one dose of PrEP, rectal tissue levels are high, they stay high, they peter down over time, but pretty impressively high. Cervical levels go up at the very beginning and then bang, disappear. Same for vaginal, a little bit better. They go up when you take the dose and then they disappear. So the lesson really is that the PrEP works differently in men than women and the counseling has to be different. So in men, we can say that, that PrEP does a couple of things. You can probably miss a bunch of doses. Not that you want to, but remember that 4-dose? That was in men. Remember Ipergay? That was in men. You could probably miss a couple doses or have incomplete adherence and be okay. But in women, you probably have to take 6 to 7 doses per week to reach the level that you need for efficacy. And there's another lesson involved here, which is that, and this PrEP patients will always ask you this, I just started my medicines today. When does my protection start? So for men, the answer is about 7 to 10 days. For women, 21 to 28 days, because it takes longer to get to the level. And so that may matter, especially if they're using PrEP for trying to get pregnant. You're just giving them a better gauge of when they can sort of work around the condom to actually get pregnant the old-fashioned way. So it's important to remember there's a difference in men and women. So there's some breaking news, important stuff to think about. It's less and less breaking every day. I feel like I have to change it, but it's like stuff outside of the study that we need to talk about. So there are some new PrEP agents. There's something called cabotegravir that's out there that works in monkeys and may work in people. It's being studied right now. It is a long-acting injectable, initially thought to be something that you could use every 3 months, kind of like Depo-Provera to prevent HIV. It is related to dolutegravir, if you all follow antiretrovirals. So it looks like it's working. There's an interesting problem with it, which is good to talk about early on, which is that if you give someone a dose of cabotegravir, 17% of them have levels of it in their body a year after that dose. Right. So it's not an easy on-off. So right now it looks as if you get cabotegravir as an injectable, if you decide to stop it and there's still risk going on for HIV, you may have to go on some oral medication to bridge you to the end anyway. So it may not be exactly perfect. So a lot of people are like, it's great for adolescents. I don't know. I don't know if it's that great for adolescents. We'll see what happens. Also, Maraviroc is being looked at, which is another kind of drug, a CCR5 antagonist, and some of the data looks pretty good. But what I honestly think is the cooler data and the cooler piece of the future for PrEP are the PrEP vaginal rings. Who's heard or seen these things? They're pretty awesome. So dapivirine is the one that's the most studied, that's been the most promoted. And what you see is, again, another graph that shows that for all comers, that placebo doesn't work as good as dapivirine. Problem is the effect rate there is about 25%. It was pretty low. But then they did some more work and they found something that's not surprising given the other PrEP data that I've given you, which is that for your younger women, it didn't work as well as it did for your older women. And at first there was some concern that it had to do with the difference in their anatomy. That's not what's going on. It's adherence. So when they actually look at the levels in the vaginal rings, they actually have this like really cool thing where they like take the vaginal rings that were used and measure the amount of drug left in them. So the more drug left in them, right? What a great job that would be. But like the more drug left in them, the more likely they weren't used. And so what they found was that the youth were less likely to use it, but when people did use it, oh my gosh, greater than 65% protection from HIV. So the vaginal ring may have legs. And then the really exciting stuff, I think, is they're combining it with hormonal contraception. So you'll have one ring that does both. There's even one that they're calling sort of affectionately the pizza, where you can add even more kinds of prevention. Like you can drop your PrEP, you can drop your contraception in it, and you can drop your like herpes prophylaxis and just use that one ring. So it's really cool. And that's coming down the pike, which is pretty exciting. So I'm going to leave that and talk a little bit about our news about PrEP use among men who have sex with men in New York. So this is the other place that I would get in trouble if I like actually put it on a slide. So I'm just going to say it out loud, and it's okay that it's going to be on a webcast. But we actually have seen increases in PrEP use over time using our sexual health survey, where we actually do online and in-person surveys of young MSM 18 to 40, and we have one happening with women as well, but we're not ready to share that data quite yet. Our 2016 data says 29% of the men we survey are on PrEP now, which is remarkable. When you look at who is on PrEP, it's kind of cool to see who actually decides to use it. So the x-axis here are certain behaviors that we ask about. So if it's blue, it means that they say yes, that they've done that behavior, and red means no. So people who did not use a condom are more likely to be on PrEP. That's good, because we learned that higher risk, by targeting people who are at higher risk for HIV exposure, it's a more cost-effective intervention, so yay. People who have more than 3 partners with no condom in the past 6 months, they're more likely to use. People who have an HIV positive partner as their last partner, they're more likely to use it. This one is my favorite. People who do post-exposure prophylaxis transition to PrEP. And that's like our strongest signal. So why do I love that? Because think about what that means. They've come to see some sort of healthcare provider for some need that they had. They got that need addressed, and then they got offered PrEP, and they went for it. So forget PrEP. I come in with a drip. I have gonorrhea, and I'm scared. And you tell me you have gonorrhea, and now we're going to treat that gonorrhea, and we're going to figure out a way to prevent HIV. Let me tell you a little bit about some New York City data that I bet you is not that different than what you'd find if you were to do the same. For people who come to our, people in New York City, men who have sex with men who are diagnosed with syphilis, primary or secondary, they have a 5% incidence per year of getting HIV from then on out. If they have a rectal STI, 8%. So I think that when you capture someone at a moment of medical need, specifically that enhances their risk for HIV exposure, that's the time to sort of pounce on PrEP and say, do you want to try this? Because people tend to listen to you. So that's our strategy in New York. All of our STI clinics, if you're diagnosed with syphilis, gonorrhea, chlamydia rectally, we're going to offer you PrEP right there that day, because we think that that's a suggestible way to actually get people on board. So I love that this is like our evidence for that. So in terms of STIs, one of the things that's sort of wrong in the world is that the guidelines are kind of wrong. So, and the CDC, Dawn Smith would stand right here and she'd say the same thing, so don't feel like I get in trouble. The CDC guidelines currently say that you should screen for sexually transmitted infections every 6 months for people who are on PrEP. In San Francisco, they did a study, and there's a similar one in New York, but I actually think the San Francisco data is clearer. And what they said is, what percentage of STDs would we have missed if we were following CDC guidelines? Who has a syphilis epidemic? Anyone? Yeah. All of us. So here's what's so interesting. So when you don't do the screening every 3 months and do it every 6 months, they miss 20% of syphilis in San Francisco. That's not going to get you very far. Overall, they missed 35% of all of their bacterial STIs had they not been screening. And one of the other things that the guidelines say is that you should do a symptom screen. So if you're not doing the urine testing and the rectal testing and the oropharyngeal testing for gonorrhea, chlamydia, and syphilis, you should just ask them, does it hurt when you pee? Does it hurt when you go to the bathroom? Does your throat hurt? Well, we kind of all know the answer to this already, but San Francisco showed it again. Burgundy means asymptomatic. Pink means symptomatic. So if you want to only catch urethral gonorrhea, then that strategy is really good. If you want to catch the other stuff, you have to actually throw a test on and not just ask a question. So I show this to remind people that the guidelines you may read will say test every 6 months. No. Test every 3 months. Don't worry, the guidelines are going to change. It's happening, but be precocious. Don't wait for them to change. You should do every 3 months. And what about PrEP breakthroughs? Well, this is the first breakthrough that was reported. So someone who we think was adherent on pre-exposure prophylaxis, who then got an HIV infection. And so the story is that this gentleman who was taken in Canada, who was taking PrEP, was exposed to HIV, developed symptoms, had an HIV test a couple of weeks after the exposure and around when the symptoms were happening, and was found to be HIV positive. Okay, so this is what people call a PrEP failure. All right, not to be a Pollyanna. I don't think of it as a PrEP failure because I'm not surprised by it. Remember 92%? That's not 100%. It's actually kind of a PrEP success, and let me tell you why. So he gets diagnosed here, then it's like a couple of weeks later, and he's on full HIV medicines and is virally suppressed. Okay, well, that's not a failure. So, I mean, I think that whatever the test result is, negative or positive, what happened was that he is engaged in optimal care for his situation. So it's not bad news or good news, it's just news. And so what happened was that because he was in PrEP care, because he had that interaction, this became really easy to do. And so, yeah, he got a pretty drug-resistant virus. Not surprising, not something that we're surprised by. That's exactly who's going to break through PrEP. So it actually also speaks to getting people virally suppressed because it'll prevent transmission of those funky viruses. And so this is our breakthrough now. So we have one that was reported in New York City as well. It's a bit more complicated in some ways with testing, but the story is similar. So this person came in for an HIV test. It was reactive. And then they didn't believe it because the pattern was a little bit weird. They repeated it. And then when they thought that it was really reactive, within 9 days, he was on medicine and was actually virally suppressed from the beginning, right? It's maybe a PrEP breakthrough, but it's not a PrEP failure. That is a PrEP success because something is happening to keep him healthy. Bottom line is what they found with this one is he had detectable drug in his hair and his blood, so it looks like the real deal, that this is a breakthrough. Again, we released all this stuff about it. We're not surprised, but we definitely want people to make sure that they test people every 3 months, which is the message for HIV, to make sure that we don't miss these. Okay, so just quickly, PrEP is pretty easy, so I'm going to go through the guidelines really quickly just to sort of remind you. New York City and New York State came out with PrEP guidance in the past, pretty early after its approval. Then the CDC came out with their really awesome document as well. And so it's not something we're making up. Everybody thinks you should do it, so you should do it. Like, that's easy. It's not something that we're just sort of tap dancing around. But there's some really important core messages. PrEP should not be offered as a sole intervention for HIV prevention. Remember my conversation about that PrEP Partners demonstration project? When you put the whole mess together, it works. Put the whole mess together. PrEP, treatment, as well as barrier protection, all those in combination for whatever works for individuals is what's going to change the epidemic. We know for a fact that PrEP should only be given to people with recent negative HIV test results. The reason that that's important is because you don't want to start someone on a partial regimen for HIV if they're HIV infected. Only negative people. And they should be at ongoing risk for HIV infection. It's also important to remember PrEP may be a part of conception for some individuals. You could prevent transmission and allow them to actually have babies the old-fashioned way. And this is all about adherence to two things: adherence to taking the medicine every day and adherence to coming in to see your provider or whoever does HIV and STI testing to make sure that you're, from the sexual health perspective and HIV perspective, healthy. This is another way of looking at the adherence, just to remind you how important it is. In the red is protection from PrEP, so meaning how well PrEP worked to protect from HIV. The blue is the percentage of people who had detectable drug in their body. So another way of looking at that line graph you saw, the more people were taking the drug in the studies, the more likely it worked. So adherence is critical to this working. But there's a couple of other important things to remember about PrEP, which is that PrEP is harm reduction it is not harm elimination. So it's neither rational nor is it expected that PrEP will directly address all sexual health issues. PrEP does not prevent pregnancy. It does not prevent chlamydia. Pretending that it does, or assuming that it does, or spinning it to people as it does, is actually doing it a harm. So again, syringe exchange doesn't prevent overdose. Syringe exchange doesn't prevent heroin use. It prevents transmission of disease. Seatbelts don't prevent cancer, right? They don't prevent cancer. So it would be weird to say that we're going to stop using a seatbelt because it doesn't prevent cancer. PrEP does not prevent STIs. We're going to keep using PrEP even though it doesn't prevent STIs. But I have an even more interesting argument for you. So if you put that seatbelt on and you drive to the colonoscopy suite, it may mean that that seatbelt has participated in you preventing cancer. If you put on that PrEP and it gets you to a clinic where someone swabs your butt for the first time in your life, screening you for STIs for the first time correctly, then maybe PrEP is helping the story of STIs as well by bringing people to sexual health care. So you're going to use PrEP to prevent HIV and do all the other stuff you have to do to prevent STIs, and you're going to use seatbelts to prevent injuries during car crashes and a colonoscopy to prevent colon cancer. But they may interact somehow. So who's a PrEP candidate? So this is the New York State list. I kind of like it because it's a bit, it's got some resolution to it. So men who have sex with men who have condomless sex. People who are in different sexual relationships, who knows if that'll change, but right now that's an indication for PrEP. Trans individuals, if they're engaged in high-risk behaviors, sex workers, injection drug users. For us, methamphetamine is a problem, so methamphetamine and other stimulant users independently are folks that we'll do this for. People who've had one or more anogenital sexual transmitted infections, including syphilis, and anyone who's been on PEP before. All things that are markers of future HIV. So there are not a lot of medical contraindications. I'm not going to read this because of time. I'm just going to tell you they shouldn't have HIV, and you better have a really recent test. Prove it. The best testing modality you have is what you use. I like to say not more than 1 or 2 weeks old, so you know that you're starting someone on really good data. The only other medical contraindication is if their kidneys aren't so good. So if their creatinine clearance is less than 60 mils per min. There are a couple of things that you have to consider, but that don't contraindicate PrEP. The first is Hep B infection. Hepatitis B is treated by the drugs that are in PrEP. There's a theoretical risk that if someone's risk changes and you stop their PrEP and they have Hep B and you stop treating the Hep B, then you're going to flare the Hep B. It's theoretical. It's just something that you need to be aware of. It never happened in any of the PrEP studies. Is the patient pregnant or trying to conceive? This may be a tool in that. Is the patient an adolescent? I don't even have to talk about that anymore. I think we've beaten that one to death in terms of the different issues we have to think about. Worry about nephrotoxic drugs, like are they taking a lot of Motrin? And if they are, talk about ways to get them off the Motrin and switch to something else. And also, if someone's at risk for bone problems, just have some vigilance about this. It doesn't mean you won't use it, but just something to think about. And if you're going to screen them for bone mineral density, just make sure you're doing it and make sure that they're aware of their risk. Pre-PrEP assessments really don't just involve medical stuff, but things that are drivers of infection, homelessness, food access, domestic violence. Ask everyone, regardless of their sexuality or their gender identity, about their fertility goals. Trans men have babies, and sometimes they want them. So just make sure you ask. Talk about partners' HIV status and connection to care, because you may be doing a little DIS work on the side by trying to get their partners in. Figure out how to pay for PrEP. I think you have some good mechanisms in mind now. And also just make sure they don't have acute HIV infection. For time, I'm not going to go deeply into acute HIV infection, but I'll remind you that it's good to get your baseline HIV test. We recommend a 4th generation lab-based test. If you don't have that, 3rd generation's fine. And if they've had condomless sex in the last 6 weeks, you should think about getting a viral load. That's different than the CDC guidelines. I actually like that better because it really prevents acute infection slipping under the radar. You need to check their kidney function. A creatinine is adequate. New York State wants you to get a full one. urinalysis to look for baseline proteinuria is a strange idea from New York State that the CDC does not advocate, and I don't either, because you don't do anything with it. You just look at it and say, there it is. Serological testing for Hep A, B, and C. 3-site screening for sexually transmitted infections if indicated, a syphilis test, and a pregnancy in females. PrEP is easy to prescribe. Truvada, there it is, I said it again, tenofovir emtricitabine, 1 tablet daily. We recommend limiting the first prescription to 1 month. Make sure they come back in, see how they're doing, some TLC, and then when they come back, you give them a 2-month supply, and then 3 months at a time so it syncs with their STI and HIV testing so they have a reason to see you other than your beautiful smiling faces. So it's really good to sort of think about timing it like that as well. And again, that may be different for adolescents. So the visit maps are pretty easy. So at that 1-month visit, you just make sure that they're tolerating the drug. If they have a high risk for kidney disease, maybe you'll check their kidney function. Then subsequent months, every 3 months you're gonna see them, HIV testing, STI testing at least every 3 months, not 6. Creatinine check at least every 6 months. A pregnancy test if they have a possibility of conceiving. And then every time you say the word PrEP, you're gonna say the word condom. Just get used to it. Whether it is a fiction or a fantasy, our job is to promote barrier protection as well, and it's good to do that. And my favorite question is, do you still need to do this? People have changes in their seasons. They leave the malaria zone of HIV. So they don't need to be on PrEP anymore, stop it. But have a really honest conversation about it. Okay, that's it. PrEP in a nutshell. Excellent. Thank you. So I think I have a flight to catch, to be there soon-ish, but I can probably take a few minutes of questions. Is that okay? And I probably have put you desperately behind schedule. Okay. I think we started a little late too, so I think I'm 5 minutes over our start time. Any questions? It's a whirlwind. Yes?
What are you recommending for your adolescents in terms of follow-up? Are you all doing every 4 weeks? Or like once a month? Or what are you doing?
We funded 3 adolescent PrEP sites to ask that very question, not as a study, but as real implementation. So I know that what they're doing is they're doing 4 to 6 week follow-ups. And they're opening the door for, adolescent clinics are different. Like, I'm not sure if you have ever been to an adolescent clinic, but you can just walk on in any old time and be like, I'm here, and they're nice to you, versus when you go to the adult clinic and they go, who are you and why are you here? So like they're sort of lower threshold in general. So we're saying that they should be seen once every 4 to 6, ideally 4 weeks, until the provider makes a decision with the patient that it's okay to loosen up. I think that's what's going on there, right? I mean, it's so obvious, like the line changes when they are seen less frequently. Any other questions? Yes.
How far along are we with the study that has the medicines before and then 48 hours after? I know I heard in Washington in May that they were in clinical trials, but I didn't know since they've already finished in France.
The Ipergay one? Mm-hmm. So I think that the Ipergay study has now been in open label and it showed ongoing efficacy, but they were taking a lot of drugs. So I think that we know the answer that it works if you're taking it pretty frequently. Problem is to recruit the study of people who have sex every 2 weeks and are only on it like really rarely. It's going to be really hard to do, so we're not going to really know the answer, I don't think. Because they're recruiting the same people. They're recruiting these like folks who are having enough sex where they're going to be taking 14 tablets a week or a month, which in that case is, or 16, which in that case is the same as incomplete adherence to daily PrEP. I'll go back there and then back. Yes.
My concern is we have to advertise this like we advertise Viagra. There are plenty of people that I know that I talked to about this, but somehow couldn't find themselves here. They're HIV positive, their partner's HIV positive. Then there are people who say, oh, I already know, I don't need to show up. Then I know there are doctors that are treating transgender people, but then they don't keep up with stuff like that.
Yeah.
So sure. I feel like we have to get beyond, just the people in this room, but make it as pervasive as your Viagra.
Yeah.
As your Viagra, what do you call it, advertisements, so people are going to their doctors and asking about it. Because all the people I tried to talk to, just little old me, for some reason just...
Little old you matters, I'm telling you, it's like a word of mouth thing. Yeah. Once they know that you prescribe PrEP or you're interested in doing it, more people will come to you. I don't want to plug the company that makes so much money off of Hep C at the expense of our Hep C patients over this, but I do want to say that they actually have launched the first branded media campaign for PrEP. I actually saw the first ad. It's in the Out One. If you want to see it, it's in Out 100, which is our Out magazine in the 100 issue. It just debuted on Saturday, on Thursday. So it's out there. Is it really good? Not to be judgmental, but Like the Viagra ads are like, we're having baths by the ocean, loving each other, and this is just like some picture of the pill with like a little squiggle around it. You're like, whatever.
I think we have to get where people go to their doctor and ask them, what about this? That's the way I see this situation, flip-flopping.
In New York, we did something cool, which was that we hired drug reps and sent them to practices all over the city. Like we were Gilead, except we were promoting the intervention of PrEP and PEP. And so we sent them to about 2,000 practices and saw increases in prescription based on that. So there's always there's little tricks you can do in CMEs that are about other topics, like embedding something about PrEP or other things if you're sending folks out to practices to teach them about we actually linked Zika stuff with our PrEP stuff. Yeah, it was, yes.
I know that on Instagram, there's organization based out of Atlanta that's called the Prep Squad.
Yeah,
and
DC too. DC has one too.
So they have really interesting social media, usually with half-naked nude, but it does get your attention.
That's what it does. That PrEP ad from Gilead is sad, I'm telling you.
And I was just thinking that I know that it's maybe a little bit racy for TV, but something similar to that. The messaging is really good. The imagery is what really catches your eye, but I follow them and I have put some of their stuff right on Facebook, but they also have a little cartoon that was really, really cool.
They're really cute.
It was cute, it was cool, it was catchy, and I put that out on Facebook, and I kept thinking, why isn't that stuff like that out on regular commercial? Because that would get the young people kind of interested in what it's real short snippets, real good sound bites, but it's not, it would catch their attention.
We did ads in New York that were really cute that were called Pleasure. You get it? Pleasure, pleasure. And so they were on the subway. Yeah, it worked. Got it through City Hall. It was on the subway as well as on TV. And we did the same thing. We made it look like a party with happy people talking about HIV prevention. And so I love the idea of it being, more for the population. You'll see, you should definitely find that Gilead ad. I'm not dissing them at all. It's fine. I'm really glad that they finally decided to do something after years of not. But I think you should take a look at it because it's pretty boring, and maybe giving them feedback from the community that you should make this a more exciting ad that sort of targets my people would be good. But I'm with you. I think it needs to be something that people are interested in. Okay, and this is my last one, or else I'm going to be living with you in Louisville, which is fine. You're lovely.
Because we have limited providers who are offering PrEP, there are other providers who maybe want to do it. One limitation is all the STD testing.
Yeah.
So what do you think about the self-collected STI?
100%. So when I did a technical assistance visit to Richmond, Virginia, and right outside Richmond, a little teeny town was starting a PrEP program. It was really cute. They were we're scared that we're not going to be able to see all the people for STI follow-up. So I said, before you open your program, figure out a way to do express visits with standing orders where someone can come just drop off specimens. If you want to see something cool, go to YouTube and find Dean Street Express. There's jurisdictions that are looking at doing something that is a very high-tech self-collection environment for STIs. It would be awesome for PrEP. We're gearing up to do one in New York like London has. If you've not seen it, it is awesome. Real-time resulting 2 to 6 hours after the tests are done via text. Dean Street Express. Super cool, super cool, the future. So yeah, my recommendation is that you sort of gear up toward doing self-collection and create express visits that require not necessarily seeing a clinician, but just dropping off specimens with some kind of standing order, or a lab slip or whatever you have to use.